So imagine you're a patient, right? And you survive this incredibly complex, maybe like a 10-hour surgery.
Yeah, a massive trauma on the body.
Exactly.
Yeah.
You make it through this highly choreographed, super dangerous medical event. But then a week later, you suffer these life-threatening complications.
Oh, wow.
And all because a routine IV was placed in the wrong size vein.
Right. Which happens way more than people realize.
It's wild. So, welcome to our deep dive. Today, we are taking you into the hidden high-stakes world of vascular access.
It really is a high-stakes world, yeah.
It is. We've taken this massive stock of medical intelligence. I'm talking masterclass audio lectures, comprehensive association for vascular access resource guides, and we're translating them for you.
Because, you know, to the average person, an IV just looks like sticking a needle in a vein.
Right. It looks so simple. But our mission today is to show you what actually happens when we access the human bloodstream. Okay, let's unpack this.
Well, we really have to rethink this entirely. I mean, a true specialist in this field, they don't just memorize device names.
Or just get really lucky at finding a vein on the first try.
Right, exactly. It's not just a parlor trick. They have to master clinical reasoning to protect the patient from, frankly, catastrophic harm.
Yeah.
Having the technical motor skill to insert a needle, that's just a tiny fraction of the job.
So what's the real work then?
The real work is seamlessly matching that physical intervention to the physical and psychological reality of the human being sitting right in front of you.
Okay, so let's start with the physical reality, like the plumbing, so to speak.
The plumbing is a great way to think about it.
Because if you put the wrong fluid into the wrong pipe, the systemic consequences are just immediate.
Absolutely immediate.
Like with peripheral varies, right? The short-term ones that usually stay in for, 72 to 96 hours?
Yeah, around 3 or 4 days tops.
The sources are super clear that they have incredibly strict limitations. Like you absolutely cannot use them for vesicants, which are tissue-damaging meds.
Never. This is a huge safety issue.
And you can't use them for solutions with a pH below 5 or above 9, or anything with an osmolality over 900.
Right. The 900 rule is crucial.
I really want to look at the actual mechanism there. Like, what does a solution with an osmolality over 900 actually do to the inside of a blood vessel?
Well, it causes a violent cellular reaction.
Violent, really?
Yeah, driven entirely by osmotic pressure. So when you introduce a fluid with an osmolality that high into the bloodstream, you're introducing a hypertonic solution.
Okay.
And because that fluid is, so highly concentrated with solutes, it aggressively pulls water out of the surrounding endothelial cells.
And those are the cells lining the vein.
Exactly. It's this incredibly delicate single-cell layer lining the inside of your veins. So those cells literally shrivel up, desiccate, and die.
Oh, wow. So you're destroying the infrastructure of the vein from the inside out.
You are. It's devastating to the vessel.
I was reading through the material on this, and the best analogy I could find was it's literally like pouring acid into a drinking straw.
That is exactly what it's like. Yeah.
Well, because the blood in a small peripheral vein just isn't moving fast enough to wash it away.
Right.
It just sits there eating the plastic.
Precisely. It destroys the endothelial lining. And that actually brings us to the physics of central dilution.
Okay, central dilution.
Right. When a medication is that harsh, whether it's super concentrated, acidic, alkaline, you need a pipe with massive, rapid blood flow.
To flush it out. To
instantly dilute the drug the millisecond it exits the catheter. This is why devices like midlines and PICCs are utilized. But their anatomical termination points completely dictate their function.
Right, because for the longest time, I just visualize a midline as like a slightly shorter PICC line.
A lot of people do, actually.
But the sources say structurally and functionally, they are worlds apart.
Completely different categories of access. I mean, a midline catheter is inserted in the upper arm, but crucially, the tip terminates in the arm.
Like right below the shoulder.
Yeah, usually right below the axillary line. It never reaches the central circulation.
Okay, so it's still just a peripheral device then?
Exactly. So it is strictly subject to all those pH and osmolality restrictions we just talked about.
Got it. And a PICC line?
Well, a PICC line, a peripherally inserted central catheter, it also enters through the arm, but it is threaded all the way up and into the central circulation.
Right into the chest?
Yeah, terminating at the lower superior vena cava, or the cava-atrial junction.
Right near the heart. Where the blood volume and velocity are, so immense that a harsh vesicant is instantly diluted before it can burn the vessel wall.
Precisely. You have about 2 liters of blood per minute rushing past that catheter tip.
2 liters a minute. Wow.
Yeah. But getting that placement right, it requires mathematical precision, Let's look at the 33% rule.
The 33% rule.
Right. Fluid dynamics dictate that the catheter-to-vein ratio must be 33% or less.
Meaning the physical tube you're leaving inside the vein cannot take up more than a third of the vein's total internal diameter.
Exactly. And the mechanism behind that rule is just fascinating. So blood flow velocity is highest in the absolute center of a blood vessel.
Okay.
When you drop a catheter into that center stream, you force the blood to flow entirely in the narrow annular space.
Like the ring around the tube.
Right, the space between the outside of the catheter and the inside of the vein wall. If your catheter occupies more than a third of that space, the friction drastically slows the blood down.
Oh, I see.
And what does stagnant blood do?
It clots.
It clots, yeah. You trigger a massive inflammatory response and induce a deep vein thrombosis, a DVT.
So it's not just a medical guess, it's literally a structural engineer calculation.
Absolutely. It's fluid dynamics, and the same logic applies to the depth of the vein you're targeting.
Oh, with the ultrasound, right?
Yeah. Using ultrasound, the ideal target depth is between 0.3 and 1.5 centimeters.
Which makes total sense mechanically. I mean, if it's shallower than 3 millimeters, there's a huge risk the needle punches straight through the back wall of the vein.
Before you can even level it out, right?
Yeah. But if it's deeper than 1.5 centimeters, the angle of your approach becomes so steep that the catheter is likely to kink once you tape it down to the skin.
That happens a lot with deep veins.
Plus, the deeper you go, the harder it is to accurately visualize the needle tip on the ultrasound screen anyway.
Exactly. And beyond the physics of the tube, you are managing biological risk.
Like infections.
Yeah. The anatomical site you choose completely shifts the infection risk profile. The subclavian vein, right under the collarbone,
Right.
historically carries the lowest infection risk because the chest is a relatively flat, dry environment with less mechanical movement.
So less movement to, like, piston bacteria into the wound tract.
Exactly. Conversely, the femoral vein down in the groin carries the absolute highest risk.
Because of moisture and movement.
Moisture, proximity to the perineum, and constant mechanical flexing whenever the patient sits up or walks.
Okay, wait. I have to stop you there.
Sure.
If central veins, like where a PICC line terminates, are so incredibly good at diluting harsh meds, and they completely bypass the risk of burning out those smaller peripheral veins, why don't we just use a PICC line for everyone?
It's a fair question.
Wouldn't tapping into the biggest, fastest flowing pipe just be the safest bet across the board?
Well, it's a very logical leap, but overusing PICC lines creates a devastating cascade of alternative problems.
Oh, really?
Yeah. PICCs are highly invasive. When you run a line from the arm all the way to the heart, you are laying down a direct plastic highway for bacteria.
Straight past the body's natural defenses.
Exactly. You exponentially increase the risk of CLAV-SI.
That's a central line-associated bloodstream infection, right?
Right, which carries a staggering mortality rate. Furthermore, the sheer mechanical trauma of threading a long catheter through the venous system damages delicate internal valves.
Oh, wow. I didn't even think about the valves.
Yeah. If you use a PICC unnecessarily for like a simple short-term hydration therapy, you risk causing massive DVTs, and you effectively ruin those central veins for future use.
So the goal is to preserve the vascular anatomy, not just exploit the biggest pipe.
Precisely.
Okay, so we've solved the physics of the vein, but none of that math matters if the patient's heart rate is spiking at 130 and they're instinctively pulling their arm away from the needle.
No, it doesn't matter at all.
Let's talk about the biological variable of fear, because having the perfect ultrasound technique is totally useless if the human being attached to the arm is terrified.
This is a critical pivot in the practice. In this field, communication is not categorized as just, bedside manner.
It's not just about being polite.
No, it is a clinical intervention. It is every bit as vital to a successful outcome as the chlorhexidine you use to prep the skin.
That's a strong statement.
It's true. If a patient's sympathetic nervous system is in fight or flight mode, their veins physically constrict.
Wow.
Vasoconstriction makes the physical insertion infinitely more difficult and painful.
And managing that starts with how you frame the why, right? Like if you walk into a room and use medical jargon like, I'm here to place a central line.
The patient just hears surgery near my heart.
Exactly. You
Yeah.
panic.
Right.
Instead, you have to reframe the clinical logic so they view the device as a shield.
Right.
You say, your medications are incredibly strong. If we put them in the small veins in your hand, it's going to burn and cause damage. So we're going to use a larger vein to dilute them safely and protect your arm.
You're providing clinical justification that inherently builds trust. You are partnering with them against the harsh medication.
Yeah.
But an intervention is only effective if you verify it worked. You have to test that communication using the teach-back method.
Teach-back is such a brilliant concept
Yeah.
because it's not a test of the patient's intelligence.
Yeah.
It's a test of the clinician's teaching.
Exactly.
Instead of saying, do you understand? Where everyone just nods yes so they don't look stupid.
Right. Everyone always says yes.
You ask, can you tell me in your own words how you're going to care for this IV today?
Right. And to guarantee they can answer that,